Thank you, Dr. Rushdie, so much. I'm really so impressed. But this is an example of a candidate who start amazing startup. And I told her we'll give you 8 by 8 in the first case because it's a little bit tricky and difficult. And then the second case, she dropped down completely. And she stand up again and they have a consecutive increasing curve until she finished the last case. Amazing. So don't panic, my colleagues, if you within the Viva uh, have lost one case or have confused or you don't know what the examiner will give me in this case. Don't think in any cases. Despite the second case was not a big issue or not a difficult, but this is a type of mental block which all of us may face in the exam. Even all who pass the FRCR from the first time face the same problem. Let's start from the last case. Dr. Roshni, I will give you 7.5 because from the first few seconds, you inform the examiner. This is a collection extended epidurally. This is any examiner wanted to know from you. You are safe or not. This is abscess, no problem. Any radiologist can pick up, but this is epidural extension, which is an emergency. She finished the case within the first few seconds, and this is amazing. And describe whatever you want to describe, but what the examiner wants from you to pick up the most dangerous. This is a right perivertebral abscess in the spinal rector muscle, extending also in the psoas. This is the main location, but it is has epidural extension. Management, epidural decompression. She smashed the case. By the way, the psoas abscess can be primary if the patient immunocompromised, have a diabetes, or we should ask for drug abuser history. Secondary, maybe secondary to appendicitis, diverticulitis, Crohn's disease, or perforated colonic carcinoma, or other causes like osteomyelitis, like aortic infection, or renal abscess. This is some information to enhance our knowledge. Case before, case before was so tricky. I love so much the way you go through. First, this is a non-breast cancer patient. This is lytic lesion, most probably malignant. Okay, then I show you this one. This is the only mistake that I will demarcate here. Why? Because this is ground glass appearance.
Ground glass matrix, yeah.
Cortex are intact. So I didn't want from you to change your diagnosis. Oh, doctor, this is not a lytic metastasis. No, please include fibrous dysplasia. Doctor, I will put first lytic metastasis, then second, I will put fibrous dysplasia. But you make another mistake. You didn't ask for previous images. This is the key in these images. In this case, we should revise and compare with previous images. If I compare, this is a polystotic, so this patient must have some examination since childhood. The case finished. Okay, my colleagues. Even this case also contains some bone scan. All are hyper intake. The solution here is in the comparing with previous images. We didn't show this one. This is the tenosynovitis case. Okay, someone didn't know what is the name of this tendons. Okay, this is in the dorsal aspect. So this is extensor. Which compartment? See, here is the Lister tubercle. This is the third. This is the second. This is the first. At least tell me this is about in the second extensor compartment. This is an intersection syndrome. intersection syndrome, either distal, when it is distal, to lesser tubercle. The lesser tubercle. I'm going now distal. This is distal intersection syndrome. What is the differential? De Corva and the proximal. Proximal intersection syndrome occur proximal to before the lesser tubercle. Okay, and de Corva occur after or distal to the radial styloid process. This one. Okay, this is a not big deal if you didn't tell these full details, but just I collect all these differential diagnosis for your knowledge. Okay, the management here may include local corticosteroid. This case, take care because very tricky case. Sometimes this is a type of calcific tendinitis. I got one case, a very vertebral retropharyngeal abscess, and it was finally due to calcific tendinitis. This is the calcification here. Okay, when you ask for MRI and correlate with the history, acute pain, calcification in the tendon, surrounded by edema. Okay, surrounded by edema. This means migration of the calcification. This is the calcification of supraspinatus, and there are another calcification within the head of the humerus. This is a migration of the loose body within the head of the humerus. This is very painful. It's extremely painful, and need subacromial anesthesia injection, anesthesia and corticosteroid. First case, you pick it up well, very well. This is a thickening of the synovium. Please train your eye for images of synovium. This is, and it shows many innumerable dark pigment. You did well when you told me I will revise or I will show the gradient, but I'm waiting from you to see blooming artifact. This is pigmented voluminodular synovitis. You did very well. This tumor characterized by recurrence and should be differentiated from other like hemophilia. Very good, Dr. Roshni. Next candidate, please, can you join?
Thanks, sir.
Hello.
Yes.
So,
1 minute.
should I describe this?
I will, yes, we are recording. Okay. 1 minute. 30 years old female patient with ventricular tachycardia for ICD insertion. Go on.
Well, this is chest radiograph frontal projection of 30-year-old female patient. There is porta cath with its tip slightly below its normal position. It seems to be in the right atrium.
Don't worry about it. Don't worry about it. What else?
Heart size also enlarged, and there is also calcific density along the right heart margin. Both costophrenic angles are clear. The lung fields are also normal. Now I am looking at the
tissue.
and the musculoskeletal.
Look at the bone. Look at the bone.
Okay. In the musculoskeletal, 1, 2. I think there is there is some in the involving the lateral. Now I'm looking at the bones and also the clavicle. There is some vaguely defined density along the lateral margin of the clavicle on the right side.
Yes.
And
what happened
also,
for both clavicle? What happened for both distal end of both clavicles? Bilateral symmetrical.
Bilateral symmetrical more on but I think more on the right side.
Yes. What happened? What happened here?
So also there is associated soft tissue component. also on the both sides. Yeah.
Patient has a catheter and has bilateral symmetrical distal clavicle abnormality and
This
reduced
could
bone
be
density.
some metabolic or the renal.
Yes, correct.
Dis-
Would you do next? Hmm.
I will refer the case. I will inform the finding to the referrer and also will refer the case to the rheumatologist and also
Why
will
rheumatologist?
suggest. Um,
This is a CT. This is a CT of the same patient.
okay. Also, yeah, I will suggest CT and both kidneys.
Yes,
Uh, both kidneys they show marked hydronephrosis, thinning of the cortex, and
yes.
also
What
there
about the
is
bone? Bone. Look at the bone, please.
bones also. Also bones. I will like to see on the bone window, but seems to be trabeculations, reduced bone density, um, and
What is this
also
appearance called?
wedging of the vertebrae and the sorry, humoral nodes, multi-level humoral nodes are also noted.
What
Um,
is the name of
so
this
renal
appearance?
osteodystrophy. Yeah, this
Excellent.
is renal osteodystrophy.
What is the name of this
So
appearance?
rugged spine.
Excellent. What will you do next?
I will inform the finding to referring physician. Also, I will do workup for the um, uh, metabolic disease and nephrologist referral.
Excellent. 10 years old male patient with multifocal bone and joint pain. 10 years old male patient.
Okay. This is MRI FIRESAT
Excellent.
um, image of a 10-year-old patient. There are abnormal intensity areas involving metaphysis of the bilateral tibia.
Excellent.
Also, I can appreciate edema of the surrounding soft tissues. Um,
Excellent. This is a whole body MRI.
okay, in the whole body MRI, also,
Look here.
yeah. Um, and so can you scroll for me, please? There is
Yes,
also
yes.
abnormal signal intensity areas at the metaphysis near the growth plate. This could be some
Give me differential diagnosis, please.
yeah, this could be areas of reconversion. These could be some hemopoietic disorder or
Yes, what else?
this could be some foci, some metaphyseal dysplasia or some
What else?
uh, uh, foci of infection.
Yes. Excellent. What else?
Also, infection, metaphyseal dysplasia, or hematopoietic
Multiple,
disorders.
multiple, multiple infection, scattered infection of the bone in
Sickle
young
cell
age.
disease. Sickle cell, this could be secondary to sickle cell disease. Um,
Okay, what will you do next?
I will inform the finding to the referring physician and will suggest further workup like blood CBC for the white cell and also hemolytic profile for the patient, and will also correlate with the finding previous imaging.
Okay, excellent. 15 years old male patient with persistent right shoulder pain.
So in this is X-ray shoulder frontal projection of 15-year-old patient. There is well-defined lucency involving the epiphysis of the right humerus.
Then
This shows a narrow zone of transition with the sclerotic margins. There is
this patient has
no
history of trauma. History of trauma.
okay. Um, so to me, there is some. irregularity of the glenoid.
Was an excellent. What will you do next?
I will request for the orthogonal view, and also I will suggest MRI or at least cross-sectional imaging. Yeah.
With MRI.
So again, please go to yeah. There is abnormal. This is FRCR image. I can appreciate that there is abnormal signal intensity area involving again the head of the right humerus, and also the line through the fracture. The linear line is also seen. This could represent fracture in the.
What is the name of this fracture?
This is Hill-Sachs.
Yes, excellent. And what
Yeah,
else?
Hill-Sachs deformity. So also,
What else?
I am. This is secondary to anterior dislocation of the shoulder. I
Okay,
am
what
looking
else?
for the. Yeah, I'm
What
looking
else?
for the labral injury. There is
Yes.
also anterior labral tear, and
Okay.
so I will
What is
inform
the
the
name?
finding to
What is the name of
bank
the
card,
lateral tear?
bank
And
card,
what will you do
bank card,
next?
bank card. Sorry, I will inform the finding to referring physician, or also urgently send the referral to the orthopedic surgeon for further management of this patient. Also, immobilization is necessary in this case.
1 month male patient with right-sided neck swelling and torticollis. Ultrasound
This is
in different planes.
sorry, these are grayscale images of what region? Sorry, in a 1 month
Neck,
old.
neck.
Sorry.
1 month old patient with neck pain and torticollis.
Okay, neck pain and torticollis. These are grayscale images, superficial probe of the neck region, because I can appreciate the vessels of the neck. There is abnormal low echogenicity areas involving the muscle, like the sternocleidomastoid muscle.
Excellent.
This is torticollis.
What's your differential?
This could represent post-infectious or post-traumatic.
Yes. What is the name of this diagnosis?
I couldn't recall. I'm just.
No problem. What is your management?
I will inform the finding to the referring physician, and also I will suggest referral to the musculoskeletal, also pediatric team for further management.
What is the management of this thickening of sternomastoid?
This needs antibiotics and rest.
There are any surgical rule or not?
Surgical diagnosis. Yeah, I'm not sure. Sorry.
No problem. 15 years old male patient, pain in the middle and the distal third of the right side.
Okay, these are frontal projections of low limb, including the both hip joints and the femora, including the knee joint of 15-year-old male. There is a well-defined region of sclerosis involving the medial cortex of the right femur. This seems to be benign. There is okay. This is a CT scan of the same patient showing. Again, region of sclerosis with nidus, central nidus. So findings are in keeping with osteoid osteoma. Findings are in keeping with osteoid osteoma. The other differential include osteoblastoma. However, in the case of osteoblastoma, the nidus is more than 2 centimeters. So I will inform the finding to the referring physician, and also I will suggest referral to the
What is the
uh,
management?
many
What is the
salicylates
man?
in this. The salicylates this respond. There is very good response to the salicylates in this case to
Yes.
relieve the pain. Yeah.
What other treatment other than salicylate?
Also, beam radiation ablation, the ablation to ablate
Thank
the
you, Dr.
nidus of
Bush.
the osteoid.
Thank you,
Thank you.
Dr. Bushra. Thank you. You did very well. This case is you pick it up very well and very rapidly, and that is what the examiner want. But you make a mistake here when you told me this is a frontal projection. This is a scout, almost a scout, because it is within a CT examination. Then this is like you said, this is sclerosis with central nidus, intracortical central nidus. That so your diagnosis is osteoma, especially it is less than 1.5 or 2 centimeter. The treatment including salicylate or radio frequency ablation. Radio frequency ablation. Other 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 differential diagnosis including osteomyelitis and stress fracture. This is a fibromatosis coli, and I bring this case for the name. Fibromatosis coli is a post-traumatic
Uh,
thickening of the sternocleidomastoid muscle. Okay, if most of us forget within the exam, this is not a big problem, but at least you should know this is a conservative treatment. This is the most important. No surgical, maybe some analgesic. So there are a thickening, post-traumatic thickening of the sternocleidomastoid muscle because some hemorrhage and fibrosis occur. As before, this case, you pick it up very well. This is a Pankert Hill-Sachs tumor, Hill-Sachs fracture associated with Pankert due to anterior dislocation. Very good. But here you take too much time to pick up this inferior glenoid fracture. This is not only irregularity, this is also fracture. And this lucency, take care, my friends, it is projectional. Here, it is projection. But here, this is the Hill sac. This is the sclerosis. How could we, my colleagues, differentiate between the normal depression of the humeral head and Hill sacs by the level of cricoid? Hill sacs should be diagnosed only if it is a depression of humeral head above the cricoid. See, this is the cricoid. This is the cricoid. Look up, up, up. Because there are normally seen depression in the humeral head. Okay. This before. This is a multifocal high signal, medullary high signal in a young patient for differential diagnosis. Number one, malignant, like what? Like eosinophilic granuloma or leukemia. Number two, chronic recurrent osteomyelitis. And by the way, it was the diagnosis. Chronic recurrent multifocal osteomyelitis. This is idiopathic autoimmune inflammatory process, and it is treated by the rheumatologist. No need for antibiotic in Kermo. It needs some anti-inflammatory and maybe some immunosuppressive therapy. Okay, my friends, this is a case. Take care, my friends, in startup case. Don't panic. He will bring you almost an easy case. Bilateral erosion of both clavicle and one central line equal renal patient, renal osteodystrophy. Don't take too much time. Don't take too much time. I describe there are osteopenia, there are cardiomegaly. Okay. But the patient went a startup case to break the ice. This is CT, bilateral atrophic kidney due to bilateral chronic hydronephrosis, and there are multiple bilateral lucency here, which represent brown tumors. Okay? Dear, there are very common cases like TB, renal osteodystrophy. You should keep them very well. Thank you, Dr. Bushra. You did very well. Next patient,
Thank you.
sorry, next candidate. Sorry.
Thank you.
Welcome. Next candidate.
Assalamu alaikum, sir.
Hi, hello. Can you
Hello,
start?
can you hear me? Yes, sir.
Yes, sir. 75 years old male patient presented with right shoulder and neck injury since 20 years ago.
Okay, I'm presented with the MR of the neck and upper chest. This is a star image. I can appreciate, I think, sir, can I see the T1? Yeah. On the T1 image, I can appreciate high signal areas which are abnormal signal intensity realized around the right shoulder joint, back, and along the lateral chest wall. As the patient has a chronic history of trauma a few years ago, I can also appreciate the, I think, superior displacement of the right humerus as well.
Don't worry about it. Look well at the cervical spine. The solution in the cervical spine here.
Okay.
Sometimes
looking
the
at
examiner, my colleagues, sometimes the examiner stop one slice and they told you the solution here. Don't discuss with him. You should try to find the diagnosis. He didn't trick you. The solution is here, doctor.
Okay, so I'm looking at the coronal star images, and there are areas of high signal intensity along the brachial plexus. The
Yes,
vessels going along the right upper arm. I can see
yes.
high signal areas along the periphery of the brachial plexus nerves. I think these could represent inflammatory process.
Correlate
Um,
with the patient trauma, all the trauma.
yeah, trauma. um,
Conclude, please, the case.
I think there is a perineural high signals on the star. It could represent a fluid signals
Yes.
or represent inflammatory process
What
uh,
is this?
due to the traumatic rupture of the spine and the shoulder superior dislocation of the shoulder.
Okay.
Um,
And what happened here for the muscle?
the muscles are showing the fatty degeneration. I mean, due to atrophy, disuse atrophy.
Are you sure this is a disease atrophy?
Disuse can be due to traumatic injury to the nerves.
No problem. 35-year-old male patient, shoulder pain for 1 month.
Okay, these are coronal images of the right shoulder of a 35-year-old male who is presented with pain for 1 month. I am looking at the muscles are showing high signal intensity on these fat site images, including the supraspinatus and infraspinatus muscles. The bulk of the muscles seem, I mean, pretty good. I can not, I mean, they're not atrophied.
What's your
Uh,
diagnosis?
the bulk is present. There is
Mm.
high signal changes in the suprainfraspinatus muscles due to the nerve injury. Um,
No injury.
at the nerve injury, sir.
Mm. What's your diagnosis?
I think, if I'm not wrong, I think if I can recall correctly, it's a Parsonage-Turner syndrome.
More than excellent. Correct. It is difficult to get the last case was more easier than this. 45-year-old female patient with foot pain. This is an ultrasound of the foot. Go on.
Ultrasound of the foot, 45-year-old male patient. This is a grayscale image. I can appreciate a hypoechoic, a well-defined area showing a caliper measurement on the, I think, transverse and longitudinal
What will you do
views.
next? What will you do next?
I would do I can if I can see a plain film or MR of the
This is MRI.
these are the T1 weighted images. Axial, I can see intermediate signal lesion, a double shaped lesion between the third and fourth metatarsal space. It is showing high signal on the star images and is crossing through the intermetatarsal space and standing superiorly as well as to the sole of the foot. This could represent a more.
This is the last case, as I think.
Yeah, this was the star image of the foot, and I could appreciate a well-defined double
Yeah,
shaped
yeah.
lesion.
You told me this is maybe a
This
mortal
may be
neuroma.
yeah, neuroma or
What
fibroma.
else? Tell me another
Fibroma.
differential diagnosis. Tell me another differential, please.
So it could be a fibroma as well.
Okay.
Okay.
What is the management?
I think it could be conservative, or if it's more symptomatic, then can be surgically removed.
Okay. Last case for you. 20 years old male patient with 6 months of painful right mid shin lamb.
Okay, I
Can I
can
start?
see that plain film of the limb, tibia, and fibula frontal projection with painful history of pain for the last 6 months. I can appreciate an area of slight sclerosis or increased density involving the mid shaft of the tibia.
Okay. What will you do next?
With also thickening of the medial cortex as well.
So what will you do
And
next?
if we can have a MR.
MRI. This is an MRI of the same patient.
Yes, this is a T1 image. I can appreciate coronal image. I can appreciate area of previously described abnormal signal on this T1. It is also showing a hypo-intense signals.
Okay, this is
And
post-contrast.
on the post-contrast, I can appreciate heterogeneous enhancement. The cortex is thickened, and at one point also there is thinning of the cortex as well. The overlying soft tissues also appear
Is this aggressive
abnormal.
or non-aggressive? Aggressive or non-aggressive?
This is
Look here.
aggressively in.
Give me differential diagnosis, please. What's your
This is
differential?
shin areas more commonly they present with stress fractures in runners, and
What else?
also
He is not a runner. What else?
with sclerotic. I think osteosarcoma could be one possibility,
What else?
and the Ewing's. And if the patient has, as
Do
the
you
patient
think
is
Ewing or osteosarcoma after 6 months will be like this? This is 6 months history of lamb and pain. What else?
yeah, yes, Same thing I was thinking. It's a long history, so I think infective process should be at the top differential with the less likely possibility of the malignant process. And I
What
would
will you do?
compare, yes, comparing
Mm.
with the previous thing if available, and also the inflammatory markers, CRP levels if available, that would also be helpful. And I would
But do you need a biopsy from this patient?
yeah, I think
No?
it's a long process, and if he's not it is not responding to the treatment, biopsy should be done for a tissue diagnosis.
Thank you, Doctora. You did very well. There are some sclerosis here. By the way, I gave you before one trick in MSK. This X-ray looks like normal. When you presented with an X-ray in MSK, which looks like normal, try to pick up either periosteal reaction or some sclerosis. I think it is either periosteal reaction or some sclerosis. If you told the examiner, oh, I could detect some sclerosis here, okay, some cortical thickening here, okay. Why? Compare this with this, with this. So the pathology here. Plus, there are some sclerosis here. Second technique, you should tell the examiner, I want to zoom. I told you before, you can zoom any image without taking a permission. When you zoom, the examiner is happy, so happy, especially when he brings some subtle cases like this. The examiner knows that you are working frequently. This is the MRI, X-ray. This is the MRI. Abnormal signal infiltration, the marrow mainly of the left tibia associated with cortical thickening. So there are a pathology here. Let's see this post contrast. The post contrast showed avid enhancement, and I show you this one, and I told you, look at this. There are cortical erosion, so it's aggressive. We are dealing with aggressive lesion. We should both all differential diagnosis, but all logical related. You told me it may be osteosarcoma. Impossible. 6 months is osteosarcoma, the patient will die. Or what is the possible differential diagnosis? Lymphoma. All of us forget the possibility of bone lymphoma. Large, long abnormal signal abnormality or mass infiltration with very minimal bone erosion. Don't forget this. Lymphoma is the only and the most important bone tumor which has a non-correlation or discrepancy between the size of tumor and the bone destruction. After that, Ewing sarcoma, but Ewing sarcoma يعني really have more destruction than lymphoma, and Ewing sarcoma is in younger age. Okay, my friends? And then you will transfer the patient to the MDT for biopsy and blah, blah, blah. Okay. In the case before, you did it very well. You pick it up well. You give a reasonable differential diagnosis. For your knowledge, my colleagues, Morton neuroma is treated conservatively by ultrasound-guided inter-digital injection of steroid and the local analgesic. Morton neuroma is a mass of peripheral nerve due to surrounding fibrosis. It is painful. Differential diagnosis either fibroma or giant cell tumor of the nerve sheath. Is before. Ooh, I think we didn't see. I think we saw this one. You are unlucky a little bit because you have two difficult cases. What happened here? If I see this in the exam and I forget the name of the syndrome, at least tell the examiner there are signal abnormality, high signal intensity in the supraspinatus and in this muscle. What's this muscle? What this muscle? This is infraspinatus. And the rest of the muscle are normal. So this is myositis. Doctor, please, I forget the name. I know it, but it was in my tip or tongue tip, but I forget now. The treatment in this case is conservative. I will transfer to an orthopedic. The examiner also will be happy. This is a Turner Parsonage syndrome. What is this syndrome? This is idiopathic myositis, my friends. Parsonage-Turner syndrome. Parsonage-Turner syndrome. This is a self-limiting and need supportive treatment. The examiner want from you to know this case is urgent or not. This case need immediate intervention or just supportive. Okay? That is why I bring these cases specifically. This case is a little bit tricky, but from the history can guess. Old age has very old trauma and complete fatty atrophy of the right-sided shoulder mass. And the examiner told you, look here, the K here. What is this? This is some finger-like projection, fluid, cyst, contain anything connected directly to the sacrum. This is pseudomeningeal. Where is the nerve here? No nerve. The diagnosis is avulsion of the brachial plexus nerve roots associated with complete fatty atrophy of the right shoulder muscles. Okay? My colleague, because this cases I know most of us didn't give the proper concern, so I bring the cases that we may didn't study well to revise. This is again avulsion of the brachial plexus nerve root. This is a pseudomeningeal post-traumatic in an elder patient. Last candidate. We have another candidate or not?
Dr. Sogia is not available. I'm the next. Can I start?
Yes. Welcome,
Thank you, sir.
doctor. 35-year-old female patient has fever, swelling, and right side pain. Go on.
Frontal X-ray of right hip joint and the leg is showing cortical thickening along the middle of the shaft of the femur on the medial side. And I can see some patchy lucencies with this cortical thickening, which I would like to zoom and also see another orthogonal projection.
And
Sir, I can.
what's the differential?
Sir,
If you know that, what's your differential?
Sir, since there is a history of fever, so my first differential would be osteomyelitis,
Excellent.
and I would further like to elaborate this on MRI.
More than excellent. MRI of the same patient?
In MRI, I can see muscular edema and medullary edema, as well as high signals within the cortex with cortical thickening, and there is a rent or a area of disruption in the cortex through which I can see the continuation of the medullary cavity through the cortical breach into the soft tissues. So this is likely osteomyelitis with fistula with the subcutaneous with the muscles. In the muscles. So
what type of osteomyelitis? What type of osteomyelitis?
So this is since cortical thickening with involucrum and sinus formation, fistula formation. This is chronic osteomyelitis, and I would convey my findings to the referring physician. And this patient needs drainage of the medullary cavity of the bone and antibiotic treatment.
Doctor. Thank you, doctor. More amazing, really amazing. 7.5. 28 days, female patient with fever, left hip swelling.
20 days.
Ultrasound. In 28 days. An ultrasound of the hip.
Okay, sir. I can see the first image.
Yes.
This is the ultrasound coronal views of the left hip joint, in which I can see that the alpha angle is reduced. It is 44, and the beta angle is 78 degree. So this is likely in favor of congenital dislocation of hip, developmental dysplasia of the hip joint. And I would like to compare this finding with the opposite side, the right side. I cannot see any joint of fusion.
What else?
Now,
What else?
uh,
Look again, please.
apart, and there is uh, soft tissue thickening along the
Yes.
ilium, and patchy
Yes.
areas of dirty shadowing, which may signify
Yes.
air shadows. So this
Yes.
is an
Yes.
abscess. This is an
Yes.
intramuscular abscess
What's your diagnosis?
within the. So this is septic arthritis of the
What will
hip
you do
joint.
next?
So this requires urgent drainage. So I would urgently convey my findings to the referring physician for the irrigation of the joint and urgent start of the antibiotic therapy of this patient.
Excellent. Excellent. Next case. Years-old patient with hand pain. Spot diagnosis, please.
So there is
What's your
expansion of
diagnosis?
the medullary cavities of the all bones of the hand.
Yes.
This may be due to chronic hemolytic anemia,
Excellent. What will you do next?
thalassemia. I would like to screen the other portions of the skeleton for other manifestation of the disease and ask the patient for previous imaging and any acute history, any recent problem for
Thank
which
you.
she can be managed.
Thank you. 20 years old female patient with mandibular swelling.
I can see a lytic expansile lesion in the left hemimandible with the cortical erosion. It is multilocular cystic bubbly lesion, and there is no soft tissue component associated with it. But I would like to see soft tissue windows also. This can be an ameloblastoma or odontogenic keratocysts because
What else?
so it can be the osteomyelitis of the mandible. I would like to ask if there is any history of fever or swelling and
No
redness.
fever.
Uh,
No fever. No tenderness.
Another differentials of lucent cystic lesion in the mandible can be simple bone cyst, an aneurysmal bone cyst, or
Excellent.
a myeloma. However, this is not the age for myeloma.
Excellent. Excellent. Next case.
65-year-old female, and there are multiple punched out lytic lesions within the skull with no sclerosis, no surrounding sclerosis. They are diffusely distributed and no sclerosis. So my first differential would be multiple myeloma. In this case, the same, this is the X-ray cervical spine of the same patient, sir.
Yes, this is a skeletal survey.
In the X-ray lateral cervical spine, I can see diffuse osteopenia of the
Yes.
visualized bones, which is also a manifestation of multiple myeloma.
What will you do next?
I will see the other areas for the skeletal survey and inform my finding to the referring physicians and refer this patient to the bone tumor MDT for further
Could you
management.
describe me the result of bone scan in this patient?
There will be cold lesions. The multiple myeloma doesn't show up on the bone scan, so skeletal survey is the ideal thing to do, not the bone scan.
Okay. Could you
Because
describe the result from urine analysis from also the same patient?
describe the result of what, sir?
Urine analysis?
Sir, Benz-Jones proteins. There will be
More than
Benz-Jones
excellent.
protein.
Like this, the examiner wanted to give you 7.58 like this. Excellent.
So,
45 years old male patient. Last case in our session, history of pain source and fever.
these are the CT scan of lower limb which is showing of both thighs, which is showing extensive soft tissue collections in the soft tissues of the thighs with air lucences within them, and extensive fat stranding and muscular edema. And I would like to ask if there is any history of diabetes or drug intake, as these findings are likely in favor of necrotizing fasciitis. And
Excellent.
thank you, sir. I would urgently refer this patient. I would urgently convey my finding to the referring physician, as this patient may need urgent debridement, since the presence of air is a poor prognostic factor in this case.
More than excellent, doctor. Really, I'm so impressed. Amazing. This is first
Thank you,
time
sir.
for
No,
you
sir.
for hot seat.
I also took the last time, but my performance was not good the last time. I was the first candidate.
No, but really, this week you are amazing. You should
Thank
you
you,
should
sir.
almost you studied hard. Very good.
Thank you, sir.
Thank you so
Thank
much, my colleague. I will wrap up the cases very rapidly. This is a case of necrotizing myositis and fasciitis. As you see, extensive peripheral enhances collection infiltrating whole the left lower limb associated with gases, necrosis. The differential diagnosis is gangrene. In my opinion, both of them are fatal. In gangrene, you didn't see any enhancement. Okay, but the examiner will, this is not a big deal. The big deal is that is a necrosis and a fatal. Immediately, this patient should transfer to surgical and ICU admission. This also very good case. It was a skeletal survey of a multiple myeloma. The difference between multiple myeloma and the METs, 2 points. First, in multiple myeloma, the mandible is affected. Second, the size of multiple myeloma almost uniform and more larger than the METs, and almost and bunched out, very well defined. Okay, if you tell these 3 words to the examiner, he will be happy. The bone scan should be negative, and the Bence-Jones protein should be found in the urine analysis. This case is very good case of differential diagnosis. This is a myeloblastoma. One of the most characteristic point of a myeloblastoma, this eroded the root of teeth. Eroded the root of teeth. The most important differential is dentigerous cyst. Dentigerous cyst is present in the same level of the teeth. But look here, the cyst here is below the teeth. It is resorbed the roots. And other differential diagnosis like ABC, okay. Please don't judge if there are or not soft tissue mass without checking the soft tissue. This is a spot diagnosis, expansion and of the whole bone with cortical thinning and osteopenia. This is a thalassemia. You were about to lose this case. It is a case of measurement of the angles, beta and alpha angle of the hip joint, but actually look here, turbid fluid with maybe gas foci, septic arthritis. Aspiration is very critical. First, to decrease the tension because it may destroy the joint. Second, to send to cytology for culture and antibiotic sensitivity. If you make some sympathy, oh, doctor, this is still young. This infection may destroy his joint. The examiner will be happy. Last and amazing answer, really. It was a case of osteomyelitis. There are thickening and intracortical lucency, and it looks like extend to the surface. MRI show abnormal infiltration and soft tissue edema. What's the difference between this and the case of lymphoma? Big difference. Not only intramedullary abnormality, but also soft tissue ill-defined signal abnormality, which almost edema. This is not a mass. The mass almost well-defined and has displacing and a mass effect on the surrounding tissue. But here, look, this is edema. You did very well when I ask you what type. It looks like chronic. Why? Because there are involucrum and there are cloaca, which is the fistulous tract. Despite there are no true sequestrum, but almost it is a chronic. Why I'm asking? Because acute has a different treatment, which including antibiotic, but chronic need a surgical interference in which the surgeon remove all the dead bone and make some graft and another different pathway of treatment. If we give the correct radiological report, the patient will be treated in the correct pathway. Thank you, my colleagues. It was a very, very heavy session today. We see about 35 heavy cases of MSK. Study well, study hard. We will meet next week, inshallah. Goodbye.
Thank you, sir.
Thank you. Goodbye.
Sir, can I have a question, please?
Yes.
Sir, regarding the case of the hip ultrasound,
Yes.
I noted that the angles are not correctly measured. Did you notice that, or you agree on that?
See, if you were in the position of the examiner, you will be concerned about the measurement or about this disaster.
No, sure.
Big
The
disaster.
priority is for the yes.
This
But
is
just
the
for
point.
a notice or just for a confirmation, I may be wrong, but
I may be wrong.
I think.
But I think
Yes, sir.
this is alpha. I think the measurement were normal. In
Yes,
the
the measurement is
description, were
normal.
normal.
The alpha angle, yes, the alpha angle should be the slope between the
No,
acetabulum and the
see here.
baseline.
This is the roof. This is the roof of the
Yes,
acetabulum. This is the ilium.
yes,
This is the labrum. I think the measurement way procedure is correct. Don't worry about
yes.
it.
This one is correct. Yes, this one is correct.
Yeah,
But
yeah.
the
Don't worry. Don't worry.
okay. Thank you so much. Thank you so much.
Welcome.